Sorry, these videos are in parts, but again, I'm trying to get IT to fix the UJA problem. But anyway, it'll still come out okay. You just have to watch separate recordings. So remember with DDH that, you have a lot of parent teaching to do. They need to monitor neurovascular checks as well. They might have, they're going to have to do some adjustments when it comes to feeding and holding and caring for their child, including car seat management when they have a child in a harness, right? Because they have to maintain the integrity of the positioning. So diapering and clothing, all of that will play an impact. So will play a role in the parent teaching. So you're going to have to work with them. Developmental tasks of the infant, they still need stimulation. They still need play and singing and talking. And so that needs to be encouraged too, just so that parents, keep the kid, that child will need to continue to grow and develop. Another way we can do management of DDH between the age of 6 to 18 months is cast immobilization, called a spica cast. So they put the baby in a spica cast, and again, this definitely immobilizes them, and maybe even easier for a parent to deal with a spica cast rather than a harness. The harness comes off a little, is able to come off so you can check skin areas, and this one you cannot. So you have to be even more aware of potential complications of a spica cast. Treatment a little bit more challenging with an older child because successful reduction is not as common. So the older the child gets with DDH, the less likely it is they're going to have a good outcome with surgery. They can try an operative reduction. I guess it's very difficult to do as the child reaches the age of 4 and older. Other types of alterations involving the hip. This leg calf Perthes disease is usually affecting the hip between the ages of 4 and 8. Usually more predominantly boys and Caucasian males. There are 4 stages to it. It is a rare childhood condition. It occurs when the blood supply to the rounded head of the femur is temporarily disrupted, and without an adequate blood flow, the bone cells will die, and this is called avascular necrosis. And when avascular necrosis happens, it can last for several years. The condition progresses. The weakened bone of the head of the femur gradually begins to collapse, and over time, the blood supply to the head of the femur will return, and the bone begins to grow again. Treatment for this focuses on helping the bone grow back into a more rounded shape that still fits into the socket of the hip joint, hopefully preventing any movement issues as the child grows and develops. Let's see, the other one, slipped capital femoral epiphysis, usually happens with adolescence. It's an abrupt or gradual displacement of the proximal femoral head on the femoral neck. So the ball on the joint of the femur. Male, female, 2 to 1. So the mean age is about 11 and a half in girls and 13 years in boys. So it happens more in boys than girls, 2 to 1. Patients are often tall and overweight. Causes unknown. Possible factors are fast growth spurts and hormonal factors, intrinsic defective growth plate, genetic predisposition, trauma, hip motion and painful limitation is really what the symptoms are. And then treatment is stabilization of the epiphysis with screw, so surgery or a cortical bone graft followed by crutches. And then there's, that's one way they can fix that. And sometimes there's no treatment if it's premature degenerative arthritis causing it, because could be that as a cause as well. Okay, then club foot. Club foot is, they're born with this deformity in their foot. And these are some congenital abnormalities that can be found in children. Sometimes they're idiopathic, we don't know. But clubfoot, deformity, this one is unilateral, bilateral presentation where there's an inward rotation of the foot. The calf usually looks smaller. And less ability for them to develop muscle strength. So basically they have this deformity. There's a great picture in your book, in your red book on page 472. The Achilles tendon is extremely tight and shortened. And with the inability to have talus and calcaneus lowered into the neutral equinus position. Basically, they have an inward rotation. The main approach to treating this is serial casting within the first week of life. So they do serial casts. The casts are changed weekly for up to 12 weeks in their first few months of life, not weeks, first weeks of life. And this allows for a gradual change in the position of the foot and the bony structure so that it can go back to normal. After casting is complete, the correction's maintained with an ankle foot orthotics or the use of, physical therapy, bars in the shoes to help hold the position. Treatment depends, whether they have success or not, really depends, but it can be fine. The big thing we want to see is if the feet appear to turn inward or they're walking on the lateral border or tiptoe walking. These are some signs that they could have club foot. Metatarsal adductus. What happened to my... Okay, it is working. I'm like, is this working or not? This is a common foot or deformity involving the forefoot only. The patient presents with the foot turned inward. So again, it kind of is similar. Abducted forefoot, a normal hind foot, and a prominent fifth metatarsal tuberosity. Treatment depends on the flexibility. If the flexible foot, there's no treatment, it will resolve spontaneously. Otherwise, corrective shoes and splinting is, they can also have serial casting if it's a rigid process. Internal tibial torsion and internal femoral torsion. These are a couple of in-toeing positions of conditions that affect the ligament laxity, the seating position of the femoral bone. So they either have medial femoral torsion or an anteversion of the femoral head or the medial rotation of the thigh. This is seen by, they could have it in the age group of 8 or 9 years of age. They can have surgical correction. Sometimes it spontaneously resolves. There's a couple pictures on page 474 for you to look at. Genus verum, we're going to talk about that. Genus valgum, genus verum, those are more congenital deformities. Bowed legs, also known as bowed legs. Genus valgum is knock knees. When we see children, we see they aren't all that common. Calcaneovalgus foot. This one is one of the most common causes of foot deformity due to packaging in the utero. So it's congenital in the utero during growth and development in utero. Sometimes confused with clubfoot. One foot, they'll present with one foot against the wall of the uterus, dorsiflexed, everted foot. They have external tibial toeing. Let's see. Treatment, usually the condition resolves itself once the infant is out of the womb and the foot is able to relax. So these are all pretty interesting. A little different. You can kind of these are not going to be on the exam, so I don't know how important these are for you to study. Because they're not that common. I guess I would just know what they are, review them, and kind of leave it at that. Juvenile idiopathic arthritis can occur as early as 2 and affect young children. Causes chronic rheumatic illness as well. This is where a lifelong, basically have to take care of this lifelong. It's juvenile arthritis, and it can be very debilitating and painful. First thing in the morning is the most painful for these kids. They usually have to take their medicine in bed before they even get up, some pain medicine. Most common bacterial pathogen, I'll let you guys look that up. Spinal abnormalities, scoliosis, lordosis, and kyphosis. Scoliosis is the one that affects a lot of children. We usually assess this at the nursing level in the schools, and then, of course, in the doctor's office during their pediatrician visits. Curvature of the spine, 10 degrees or more on X-ray. The level of the curvature, known as Cobb's angle, depends on whether or not they're going to have bracing, surgery, or nothing, watchful waiting sometimes. These are all caused by a couple of different things, right? Idiopathic, which we don't know, congenital, inside the womb, or neuromuscular disease. Very common for people to have different levels of scoliosis. Some of you might have scoliosis. Again, there's quite a bit in your book on page 481, how to test for it, what we can do for treatment with different levels, degrees of scoliosis. If they're going to have spinal surgery, post-spinal surgery, where they would put rods in to kind of line up the spine, then they would need log rolling after, cough and deep breathe, sometimes MPO for a little while, and NG tubes, neurovascular checks. These are all monitoring we would do post-op. And pain. Of course, pain is going to be significant in anyone who's had surgery. The book doesn't talk a lot about surgery, but it does have a little bit in there. The type of curves will depend, the curvature of the spine will whether or not they put a cast or a brace or do a surgical intervention. And I guess that's all I have. And I know I rushed through some of that, but again, I'm going to go over a sort of abbreviated lecture on Thursday to make sure I include anything that's going to be really on the exam. And then the rest of this is great to know information, not necessarily must know for the test. You can review some of this, like juvenile idiopathic arthritis. Not common. Again, some of these things that we talked about with pediatrics is not that common. You might see more of them if you're working in pediatrics or in a pediatric unit. where kids would go when they